All right, guys, it is 2:02. So please type in your name in chat, and I'm going to start recording.
Recording in progress.
Give everyone another minute or so. Let's go ahead and get started. Can everyone see my screen? Yes. All right, awesome. Okay, so today we are going to talk about eating disorders, specifically anorexia, bulimia, and binge eating. Um, I believe all of you should have taken the free quiz. Is that correct? I'm not sure how women's health works. That's good. Did you take a quiz?
I think there's a
Oh,
checkpoint
okay.
after the class.
Oh, it's after the
Um,
phase. Is it after the class? Cool. All right. Perfect. Okay, let's go ahead and get started then. Okay. So, let's go ahead and if you have any questions, please make sure to like unmute yourself and say it. I generally don't look at chat when we're doing a Zoom virtual class because I can't focus both on the projection as well as the chat. So if you have any questions, either put like a little thumbs up or hands up in your chat window or in the profile window, or just unmute yourself and interrupt me. Feel free to interrupt me. Okay, so we are talking about eating disorders. Let me minimize this. Okay. So our objectives for the next hour or so is going to be to recognize the differences between the three major forms, anorexia, bulimia, and binge eating, identify the diagnostic criteria for the three, analyze non-pharm approaches to eating disorders, and then evaluate treatment regimens, which includes both pharmacological and non-pharmacological approaches to our eating disorders. So just as a background, around 9% of the world has been affected by eating disorders, whether or not it's anorexia, nervosa, bulimia nervosa, binge eating, or some of the other more obscure ones. Um, it is one of, or specifically anorexia, is it's not a common psychiatric condition. However, it is one of the more fatal ones. There's a lot of medical complications that go alongside anorexia nervosa. And even if you are able to recover from that psychiatric condition, some lingering medical condition can also, you know, be long term for you, especially your growth, reproduction, bone health. All of that is affected by nutrition, which, of course, eating disorders are inherently affected by. About 26% of people with some sort of eating disorder attempt to commit suicide, which is a large percent of the people that have an eating disorder. The typical suicide rate is around, I believe it's around 10-11%, depending on the condition. So depression and schizophrenia will have a higher suicide rate than other psychiatric conditions, but 26% is a large percent of people with a certain condition um, committing suicide. And it does cost around 65-ish billion in estimated costs. And this is also the medical costs that you receive when you are admitted in the hospital, both medically and psychiatrically. The lifetime prevalence of these three, the major disorders, are going to be around 1% in women. As you can see here, it is a larger percentage, or at least double or triple, depending on which condition you're looking at, compared to the prevalence in men. For example, bulimia is about 1.5%, and men is about 0.5%. However, if we look at the treatment for eating disorders for females and males, if you compare the two, we see that in some of these instances, you do have men actually going out and seeking treatment for these conditions. Maybe it's a societal condition where females are more inclined to just tough it out because of perception issues. But we do see, for example, in anorexia nervosa, more than twice the amount of men seek help, even though only about a third or double the amount of women have anorexia as opposed to just less than around 3.3% of men um, suffering from this condition. So we really just depend on both who has it as well as the perception in society where men apparently feel more free to go out and accept treatment for eating disorders as opposed to women. And if we look at the lifetime comorbidity rates of other conditions alongside these eating disorders, they break it down between anorexia nervosa, bulimia nervosa, and binge eating disorder. There's a lot of psychiatric comorbidities that go alongside these conditions. For example, anxiety, mood disorders, and impulse control. It varies between disorders, but if you look at bulimia, we can see that bulimia has around 80% of people that suffer from bulimia also suffer with some sort of anxious disorder. 65 or 64% of them have some sort of impulse control, which kind of makes sense because of the binging and then the purging is sort of it's both a psychiatric and an impulse condition. And then almost all of them, 94% of people that have bulimia nervosa have some sort of other psychiatric disorder, whether or not it's the anxiety, mood, impulse control, or substance use. There are a couple other ones, for example, personality disorders, um, concentration and attention disorders, so any sort of disorder. About 95% of bulimic patients have a comorbid disorder. When we're looking at age of onset, this typically presents itself in the younger age. So adolescent all the way to approaching adolescence or emerging adulthood. The age of onset is typically around 18, 19 years of age for anorexia and bulimia, and slightly older for binge eating disorder. And this does not vary between men or female. So it's a younger age of onset for these conditions. Sorry. Okay. So when we're talking about eating disorders, we already talked about anorexia nervosa, bulimia, and binge eating, which we will definitely discuss those in the next hour or so. But there are a couple other ones that the DSM-5 recognizes as complete eating disorders that are separate from the three that we've mentioned. So the three that we'll briefly touch on is going to be ARFID, which is avoidant restrictive food intake disorder. And that one is, you can kind of think of it as an extremely selective eating, up to the point of little interest in eating. So RFID typically is both a condition within the mind, like you don't want to eat it, but it's also a sensory condition. So it can also show up as, I don't like to eat bananas because they are too mushy, or I don't like the smell of certain food, so therefore I won't eat it. So this is extremely selective, and in extreme cases, patients that have RFID have little interest in eating. Kika is a persistent eating of non-nutritive or non-food substances. Basically, they're just eating a certain thing. If you look at some literature, there's a couple of very interesting Pika patients that discuss their need to eat like toilet paper or regular paper or leaves. Well, leaves can have some nutrition, but they're generally non-food substances. So these are persistent. These are obsessive. They can't really think about why they're eating it, and they're not associated with cultural practices or traditions that sometimes um, can can sometimes be associated with persistent eating of non-food items. So as long as it's non-cultural, non-traditional, and they're persistently eating it, it's pica. And rumination is, if you understand biology, rumination is when you ruminate, is when you eat something, then you eat it again. So repeated regurgitation of food, not attributed to a GI medical condition. So there is no underlying gastrointestinal condition that's causing them to either not fully digest or some sort of GERD. Sometimes you have reflux. That is not rumination because you're not actively eating it. So what happens is you eat it and then you regurgitate it back in your mouth, eat it again, which is like ruminants. If you know biology, is going to be like a class of animals that have like that second stomach. We as people do not have a second stomach, so if we do that, that is an eating disorder that's called rumination. And these are not.
Dr. Holmes,
What's up?
are these people? I know that pica or pica, it's they are like normal cognitively, but how about the rumination? Is that a patient that is not cognitively functioning well, like a bedridden patient, or is it a normal person otherwise?
All these are very rare conditions. So if we saw earlier that anorexia is 0.9, these are even smaller than the 1% of the population suffer from these conditions. Rumination, they can be regular person. You actually might not even know they're ruminating because it's pretty silent. Um, if you're talking about bedridden people, if it's bedridden, that might be considered another underlying medical condition that's causing them to regurgitate, not because they want to, but because the physical condition is telling them to do it. So if it's an underlying medical condition, it's typically not a psychiatric condition.
So these people have control over it. They are doing voluntarily.
Yeah, so you are controlling you kind of throwing it up and eating it again. So if you have some way, if for some reason you're not able to control that, for example, GERD can loosen the sphincter between your esophagus and your stomach, so you have reflux that's accidental. you don't intend to throw up or you don't intend to regurgitate a little bit of your stomach content. So that is an underlying GI condition. That is not rumination.
Thank you.
All right. So other eating disorders, these are not DSM-5 classified disorders, but orthorexia nervosa is preoccupation with healthy eating to the point where you feel very restrictive, or it causes you severe distress if you violate that healthy eating focus. And then exercise anorexia is basically anorexia, but instead of restricting yourself to eating, you're restricting yourself to eating and you're exercising to the point of malnutrition, injury, or death. These are not, once again, these are not DSM-5 categories. These are just additional categories of pretty much anorexia. So moving away from the other three, which is ruminant, pica, and ARFID, we have anorexia nervosa and bulimia, and then binge eating, which we'll talk about later on. Anorexia nervosa is an eating disorder characterized by a pathological fear of weight gain or of being fat, and that can manifest in faulty eating patterns, malnutrition, and unusually excessive weight loss. And then bulimia nervosa is an eating disorder characterized by recurrent patterns of overeating, and then followed by inappropriate measures to prevent that weight gain. So methods to either purge yourself or either through the mouth or some other ways to basically lose the calories that you just intaked. Specifically for anorexia nervosa, our diagnostic criteria is going to be restrictive or restriction of energy intake relative to requirements, leading to a significant low body weight in context of age, sex, developmental trajectory, and physical health. You also need to have an intense fear of gaining weight or becoming fat or persistent behavior that interferes with some sort of weight gain. And then, of course, there's the altered perception of one's own body weight or shape. Self-worth is influenced by body weight or shape, or persistent lack of recognition that your low body weight is a serious issue. So those are the three categories for diagnostic criteria for anorexia nervosa. Further classification of anorexia nervosa is you can have a restrictive type and a binge eating or a purging type. All of these have temporal components, so you need to be doing this for a period of X amount of months. You'll find out next year when you go through psych that most of the psychiatric conditions have some sort of temporal component. You need to be doing X behavior for a Y amount of time. For anorexia, it's 3 months. You need to have done something within the last 3 months, either not purge or purge, depending on what type you have, and that's going to classify you as anorexia nervosa restrictive type or anorexia nervosa binge eating purging type. So the restrictive basically it's based around whether or not you've had these episodes of binge eating or purging. If you have, you've got binge eating. If you don't, you've got restrictive. You're just solely restricting the amount of food that you're taking. When we're talking about anorexia nervosa severity, you can go from mild anorexia to extreme anorexia. This is based off of your BMI. So if you have mild anorexia, meaning you are restricting your diet, you have these persistent negative thoughts about your body shape or weight, and you are doing behavioral patterns to limit your food intake, and your BMI is greater than 17, you've got mild anorexia. If you go all the way to extreme, that's a BMI of less than or equal to 15, and that is severely undernutritioned. The average healthy body weight is above 18 BMI, up to, I think it depends on your height, but it's around 23, 24 for overweight and obese. So you are very far away from BMI of healthy, which is around a 20-ish, 19 mark, with an extreme weight of BMI of 15. Any questions about anorexia severity? All right. Now, talking about bulimia nervosa is a recurrent episodes of binge eating characterized by eating within a 2-hour period an amount of food that is larger than what most individuals would eat in a similar time frame. And this does not include holiday eating. So, for example, if you all just came from Easter and you ate a whole bunch of ham in Easter, that does not count as the average amount of food that one would take in an average eating. So your typical lunch, your typical dinner, if you eat a larger amount than what you are normally eating for that meal, and then you cannot stop eating or control yourself eating, followed by a inappropriate compensatory behavior to prevent the weight gain. Okay, so that's what's the difference between binge eating and bulimia nervosa, is that you have this compensatory behavior either through misuse of laxatives, diuretics, other medications, or mechanically induced, that's going to basically purge yourself of what you just ate. Once again, this needs to, on average, needs to occur once a week for 3 months because of that temporal component. Your evaluation of your own self it's unjustifiably influenced by body shape or weight gain. And of course, this does not exclusively occur within episodes of anorexia nervosa. So kind of a restrictive diagnostic criteria. Bulimia nervosa also has a severity scale similar to anorexia nervosa, where you go from mild to extreme. That, however, is determined by the amount of episodes of binge eating and then the compensatory purging you have per week. So if you have 1 to 3, you have mild bulimia all the way to greater than 14, which is around twice a day for the entire week, then you pretty much have extreme bulimia nervosa. Presentation-wise, you can have anorexia nervosa and bulimia nervosa at the same time. Typically, sometimes though, it's more prevalent towards one type. So if you look at the anorexia to bulimia nervosa, it happens about 20 to 50% where someone will switch from anorexia nervosa and then end up having a bulimia nervosa as another eating disorder or as their ultimate eating disorder. They're transferring from one to the other. That percentage is actually a lot less when you switch from bulimia to anorexia. The key part between anorexia and bulimia is that for anorexia, you have to have a body weight that is less than 17. That will qualify you for the mild all the way to the extreme. For bulimia nervosa, you can actually have a normal body weight. You're just doing the purging. So you're eating a lot and then you're purging, some sort of compensatory behavior. But your body weight can be normal. It can be within that normal 18 to 23 BMI. So our clinical presentation-wise, for anorexia nervosa and bulimia, you both have some form of purging or vomiting behavior. Specifically for anorexia nervosa, it's the binge eating purging type as opposed to the restrictive type. But for bulimia, you've got it across the board. For anorexia nervosa, you're limiting your food intake. For bulimia, you are having a recurrent binge eating followed by compensatory behavior. Like I mentioned, you have normal weight for bulimia. But the compensatory behavior can also be excessive exercise. For anorexia nervosa, you have excessive exercise to try to restrict on top of your restrictive diet. And as we talked about earlier, they have these comorbid psychiatric conditions like anxiety, like depression, like impulse control disorders. That's pretty common between both anorexia and bulimia. Some other clinical symptoms that a patient might present with. So for bulimia, the major part is that you're vomiting a lot. So you could have someone that has chronic upper respiratory tract infections because you're basically exposing your esophagus and your throat to things that it typically wouldn't have. You'll have poor dental, poor teeth issues. You might go to the dentist a lot. You might have a lot of cavities. Not because you're eating a lot of sweets, but because the acid from your stomach is eroding your teeth. For anorexia nervosa, you could have dry, brittle fingernails or hair because you just don't have the minerals or the necessary components to build that part of your body. Your skin might be dry, it might be flaky. You're going to be nauseous a lot, like lightheaded, very weak for both of them. For behavior wise, for bulimia nervosa, you could have someone that eats pretty normal amount, then excuses themselves to go to the bathroom on almost every meal, in which case they are doing the compensatory behavior. For anorexia nervosa, they're just pushing their food around. They're refusing to eat even salads, even small caloric intake is something that they are loath to do. So we have a patient case here. G. Hadid is a 19-year-old Caucasian female presenting to the ED with heart palpitations. She additionally reports having some chest tightness and some difficulty swallowing. She reports no prior medical history, but a medical history reveals that she herself reports no prior medical history, but a med history that someone else has done reveals that she's gotten prescriptions for alprazolam, for anxiety, and phentermine 30 milligrams by mouth every morning before meals. On examination, she was found to have a BMI of 16.5. Her lab determined with a QTC of 465, but was otherwise within normal limits. And then she was given a liter of normal saline and released after some observations. So, what are some pertinent positives for this person, for Jihadid, about an eating disorder? Anyone?
Phentermine use.
I'm sorry, what?
The phentermine use.
I can't hear you. Very quiet.
The phentermine use.
Yes, the phentermine use. So, what is phentermine used for? Do you guys know?
Weight loss.
It's weight loss. So, it's a weight loss agent. So, yeah, phentermine use. Remember that for some of our disorders, we can have substance use or addiction components to it. And the addiction is pretty much either to medications that help them purge or medications that help them lose weight. And phentermine is one of those. Phentermine is a weight loss agent. So, absolutely. Anything else? Oh,
Moderate.
yeah. So she is her BMI is 16.5. A normal weight person would have anywhere above an 18.5 BMI, so she's definitely underweight. She could just be malnourished as a child. But that is a marker of someone that could potentially have some sort of anorexic features. Anything else?
The age.
Age. Yep, 19-year-old. So that is prime time for someone to develop or at least to present with a eating disorder. Anything else?
The sex.
Sex. Yep, female. 3 times the risk if you're a female for bulimia and for anorexia, as opposed to male. What about the last sentence? Not the normal saline, but the last sentence. You guys remember what a QTC is? Or we're taught what a QT is?
Yeah, that's the QT interval. That's for the EKG value.
Yes. So that is the peaks of your heart. So your heart is beating a certain rate, and that the QTC will tell me if you have an abnormal rate of beating. A high interval. So she has a moderately high. It's above a female of her age would be. So with an eating disorder, there's a lot of medical comorbidities, and cardiovascular is one of them. Because you're just restricting your amount of electrolytes you're taking, and cardiac muscle requires things like potassium, like sodium, like calcium, and you are not intaking those. So we'll talk about that in a little bit. But a high QTC is a marker for potential medical comorbidity alongside anorexia or bulimia. All right, so what other exams could be conducted to further diagnose an eating disorder? We already have that BMI. We've done an EKG. We could do BMPs to look at her electrolytes. Look at her look at her urine to determine if there's any sort of protein in there that would show us that her body is basically eating itself, trying to to have the nutrients to maintain life. So BMI is a pretty common one. We already did an EKG, but we can do a further EEG, which is looking a little bit further into the heart. Yeah. And then given her presentation, what do you think she has? Ben already said it. I will call on someone. I'm gonna call on Carla. What does she have? Yeah, Carla's not here. Shilabet, not Shilabet. Alam, what does she have?
I would guess anorexia.
Mm-hmm. Yep, she has anorexia. So the markers are going to be her low BMI. There's more concerns for heart conditions for anorexic patients. And the phentermine is a good red flag for that. Okay. So there's a lot, we've already kind of mentioned it, but there's a lot of medical considerations when you're talking about someone with an eating disorder. You can have imbalances in their acidosis, alkalosis, which is the pH levels of their blood, cardiac dysfunctions like arrhythmias and QT prolongation, irregular menses, So your body is working hard to basically live, and it's going to shut off things that it doesn't need to live, and reproduction is one of those things that doesn't need to live. So it will start shutting down reproductive organs. Or pharyngeal issues, that's for bulimia. That's the one with the upper respiratory tract issues because of all of the acid that's coming up from your stomach. Osteoporosis is some malnutrition issues, dental issues for bulimia. And then refeeding syndrome is going to pop up later on when we try to re-nourish our patients. So when we're talking about cardiovascular issues, we probably should try to conduct a baseline EKG or EEG. You guys already kind of mentioned what that is, but that looks at the heart conductance. And we're going to want to avoid any sort of QT prolongating medications. I'm not sure if you've encountered any of those yet. There's a lot in psych that end up prolonging the QT. And we definitely don't want to exacerbate an underlying condition that could get worse for the patient and give them arrhythmias, give them cardiac abnormalities that they no longer have, some valve issues. And then we should assess the electrolytes on a yearly basis once we've determined that, yes, they have an eating disorder and we are in the process of treating it. We should have these assessments on a yearly basis. When we're talking about irregular menses, this can be anywhere from up to irregular menses to amenorrhea, which is no menses. The primary treatment for this is going to be just weight restoration. So getting the body up to its normal weight, normal nutrition level. Your body will start feeling that it's okay to start shunting its energy back to the reproductive organs. There is some conflicting guidelines for use of oral contraceptives to help regulate menses. The American College of Obstetricians and Gynecologists do not recommend this for patients that are suffering from an eating disorder with amenorrhea. However, when we look at osteoporosis is linked with, once again, weight restorations as the most effective treatment. However, because it's linked with amenorrhea, and there's a bunch of studies out there saying that oral contraceptives could be used to help restore bone mineral density. There's the conflicting guidelines on whether or not you should be using it to regulate menses, but also use it to regulate or to help with a potential for osteopenia or osteoporosis. But if someone is suffering from osteoporosis, we should consider the typical agents, which is bisphosphonates, anabolic agents like turpentide, also our typical supplements with calcium and vitamin D to help with bone mineral replacement. So osteoporosis is typically a malnutrition issue. So you're not getting enough calcium from your diet, therefore your bones aren't being structured correctly. So which is why weight restoration is going to be the best thing, because that requires you to take nutrients in and replete the amount of calcium and vitamin D that you're losing from your general diet. But in general, if you already have osteoporosis, you're going to want additional supplementation to go with what your diet should be providing. And then refeeding syndrome is typically when we are going through and renourishing our patients. We need to control the rate that they are renourished, because if you give them too much, you're going to cause what's called refeeding syndrome, which could be a life-threatening condition. The hallmark biological marker of refeeding syndrome is hypophosphatemia. But the symptoms could include anywhere from rhabdomyolysis, hemolytic anemia, cardiac arrhythmias, including QT prolongation, seizures, coma, death, if you feed someone too fast from a malnourished standpoint. So we have to slowly increase their caloric intake on a daily, weekly basis before we consider them up to the typical levels that someone would be eating. And these are just other lab abnormalities that may show up and what labs we should do or tests that we should do for our patients. We already talked about cardiovascular, metabolic with electrolytes, but we also want to look at the liver function for GI, renal function for genitourinary, look at the sex hormones and gonadotropins for the reproductive organs, and then look at our bone density or DEXA scans for the bone mineral loss for osteoporosis. All right. So that is the underlying medical conditions. Let's talk about treatment. Non-pharm treatment is going to be the mainstay treatment for any eating disorder. We'll talk about this later, but pharmacologic treatment is almost non-existent. So all of the guidelines say use non-pharm first. Psychosocial therapy And if that's not enough, or you don't see enough traction in gaining weight or changing their behavioral patterns, then you can start adding in pharmacotherapy if that's something that's useful, or you think they're at a stage that they can use pharmacotherapy. So there's a lot of non-pharm treatment that are available to patients. We have the typical cognitive behavioral therapy is going to be your mainstay, your gold standard. And then, of course, you've got other ones. The ones for anorexia is really going to focus on family therapy or group therapy, especially if you're doing outpatient support, which we'll talk about also. But we'll find out that we'll talk about it in family martial therapy or marital therapy. It's looking more of a group dynamic, cohesion, social support system, whereas cognitive behavioral therapy is teaching you how to change your way of thinking. I know in a personal level. So for CBT or cognitive behavioral therapy, it's designed to enable people to establish links between thoughts, what their perception is, what they're feeling about eating, why they're not eating, and their symptoms, and then evaluate that perception of me not eating is bad versus which is the normal perception, versus their maladjusted perception of me eating means I lose weight, which is good, not a good mindset. So we're thinking about monitoring our thoughts, monitoring our feelings, and then adjusting behavior to evaluate those perceptions. And this will help reduce your stress. This will provide alternative symptoms for coping. Um, and there's a special CBT called enhanced cognitive behavioral therapy that eating disorder, specifically anorexia, is very useful for. So for enhanced cognitive behavioral therapy, cognitive behavioral therapy is a long time. Typically, it lasts about 16 weeks for typical ones. For enhanced, it can go up to 40 weeks, depending on whether or not you're doing focused or broad cognitive behavioral therapy. So we're talking months of hard work for the patient to change their perception. That's really all we can do. We have to change their mindset of their that their body size or their body weight is normal or not normal, depending on if they're anorexic or binge eating. And then we need to short circuit the maladaptive perceptions that the patient has. So there are 4 stages to enhance cognitive behavioral therapy. The first stage is to establish the treatment goals, establish a personal weight gain, establish personalized formulation, and provide education. Typically, this lasts about 4 weeks. And then stage 2, once you've established what the goals are and you've determined, given them the education on what their disease and what their condition entails, we're going to talk about identifying the problems and barriers to engagement. So if you think back to motivational thinking, enhanced cognitive behavioral therapy takes a lot out of motivational interviewing. What we went over that in Care Lab, so it really takes a lot of the same ideas and just repackages it into enhanced cognitive behavioral therapy. So stage 2 is you're identifying the problem, and then what are problems or barriers to engage the patient in their active weight gain or active thought change. Stage 3 is you're going to address the key process that are maintaining the eating disorder. You're going to incorporate self-evaluation or overregulation of shape and weight. So now you're really digging into the perceptions of weight loss or weight or body weight or body shape. And then you're going to introduce or address the interpersonal, which is the social aspects that are kind of influencing what someone believes on why they think their body is perceiving their body incorrectly. This is the larger part of your therapy. So the previous stage 1, stage 3, stage 1, stage 2, that could encompass anywhere between 1 to 2 months. Stage 3, you're going to put a lot of sessions in stage 3. And then stage 4 is once you've determined what everything is, the perceptions that's wrong and how you want to change it, you're going to want to maintain progress and then ultimately reducing the risk of relapse for our patients. So this is typically the last couple of sessions, and then we start decreasing the length of time between sessions when a patient reaches stage 4. Interpersonal psychotherapy, however, it focuses on relieving symptoms by improving interpersonal functioning. So while cognitive behavioral therapy is inward focus, it's focused on your perceptions. It might have some influence from social or interpersonal experiences, but really you're trying to change individual or personal thoughts and patterns. Interpersonal psychotherapy is you are incorporating social aspects between either family or friends, or addressing relationships between your significant other. This can be a one-on-one or group format. It's structured, and it differs from CBT by focusing on maladaptive thoughts as they relate to interpersonal relationships. So, like I mentioned earlier, it's the maladaptive thoughts as they relate to the person, which is CBT. This one is going to be the maladaptive thoughts as they relate to relationships that that person has with other people. So there's a lot of studies out there looking at non-pharm therapy. This one by Fairburn looked at is a randomized control trial looking at psychotherapy in bulimia nervosa. They found that there was a high rate of attrition and withdrawal for patients who receive behavioral therapy, and patients that received the cognitive behavioral therapy and interpersonal therapy were equivalent and had lasting changes across all symptoms of their condition. This one looked at cognitive behavioral therapy, and so basically the same thing, CBT and IPT for bulimia nervosa. This one was done by Agres back in, I believe, 2000, early 2000. They found that cognitive behavioral therapy was significantly superior to IPT at the end of the treatment phase, in which case 29% of the patients recovered from just pure CBT, as opposed to 6% that that benefited or they recovered with just interpersonal group therapy. Any questions about the non-pharm treatment available to the patient? We only really covered two of them. There's a whole lot of them. This is going to be gold standard. Everyone should get this, regardless of their severity. But once this has been implemented and you're not seeing benefits in the patient, then that's when you can start reaching for the pharmacotherapy. All right. So when we're talking about treatment, this is now medical treatment, not just psychosocial or psychotherapy treatment. You have an option between inpatient or outpatient treatment. Inpatient, of course, you're admitted to the hospital, you're being treated by a team, and you can't leave. Outpatient is you're treated either in outpatient clinic, you're able to go home on a daily basis, or you're being treated solely at home, and you have your own personal responsibility to make sure that you are proceeding with the treatment as planned. Depending on what your medical stability is, depends on whether or not someone's going to recommend pure inpatient, a partial hospitalization, which is a mixture of both. You'll go to the hospital for like maybe 4 to 6 hours a day, then you'll go home for the rest of the day. Versus outpatient, which is all outpatient. You're not even setting foot in a hospital unless you're seeing your psychiatrist. So when we're looking at medical stability, anorexia nervosa and bulimia nervosa have a lot of medical conditions that could flare up because of the malnutrition that's associated with these conditions. So if any time a patient has any of these conditions, heart rate less than 50 beats per minute, systolic blood pressure less than 90 millimeters per unit of mercury, any sort of arrhythmias, temperature less than 96 degrees Fahrenheit, a body fat less than 10% of their total body, and any refusal to eat, they are getting inpatient therapy or not extreme, but advanced partial hospitalization. You need inpatient medical help when you reach the set of medical conditions. For bulimia nervosa, we're looking at serum potassium less than 3.2. Remember that potassium, chloride, sodium are all cardiac, and calcium are all cardiac electrolytes. So when they start dipping low, we start getting worried about your heart. Esophageal tears, which is going to be due to all of the throwing up that you're doing. Your esophagus is going to potentially get damaged by it, and if it's tearing at any point, we need to go to the hospital because that also is how you breathe. Hypothermia, which is temperature less than 96, suicide risk. I can never pronounce this, but blood when you're throwing up, 100%. Do not pass go. Go directly to the hospital. Okay. And then, of course, if you fail to progress in outpatient therapy, then you're going to be submitted to either partial hospitalization or inpatient hospitalization. Any questions about medical conditions that's going to tell someone you need to go to a hospital and be treated inpatient? when we're talking about anorexia nervosa treatment progression, so there's a lot of steps that go in a patient's being treated for anorexia nervosa. There's medical stabilization, which is going to be fix all of this to make sure that the patient can live long enough to, get treatment. Nutritional rehabilitation, which is at one point what give them enough food so their body starts functioning as what a body should be functioning. Weight restoration, which is different than nutritional rehabilitation. Weight restoration is getting you to the proper body weight. Nutritional rehabilitation is just getting you the right nutrients so your body can start functioning as it should be functioning. And then once all of those are set, we're going to maintain the weight gain that we've gotten. So this is the end game for an anorexia nervosa treatment. So when we talk about nutritional rehabilitation, this once again can be conducted in the hospital, partial hospitalization, or outpatient. If you are markedly underweight, you should be conducted in a hospital setting. Weight restoration, once again, the location can vary depending on their medical and psychiatric condition. If they're adolescent or emerging adults like 18, 19, 20, the recommendation is to be treated outpatient to give them that home setting and that social support that they have. Because once you go inpatient, you end up not having that support. Limited visiting hours are limited. It's a very jarring experience for someone. So we prefer for them to be treated at home, outpatient, where they have the stability and the familiarity with family and friends, as opposed to inpatient setting. But if that's not enough, as if they have not seen improvement in 6 weeks in this behavior, then they're going to be escalated to partial hospitalization or inpatient hospitalization. For our target weight goal, so this varies per person, but in general, if you, depending on your location, the inpatient weight goal is going to be around 2 to 4 pounds per week, which isn't a lot. Because once again, remember, we can't have someone put on a lot of pounds. That's going to potentially cause refeeding syndrome. Your body has too much of something and it doesn't know what to do with it. And your body's used to your restrictive diet to the point where even just like a regular amount of food is going to tip your body over to refeeding. So depending on where you are, your goal, your typical goal for weight gain is going to change. The more that you are watched as an inpatient, the more we're able to observe you. The higher we can go, the more we can put on a rapid basis, so 2 to 4 as opposed to 1 to 2 when you are in an outpatient setting. When you're doing weight restoration, you should also include BMI percentiles, as well as menstrual history, because that's once your body starts recovering enough, you'll start menstruating again. And that's a sign that your body has reached a point that we need to either move up on our treatment progression or change our psychotherapy to account for your body acclimating to the new weight restoration that we've just provided. All right, any questions about these treatment progression? All right, so once we determined that they need treatment, psychotherapy isn't enough, what pharmacological options do we have? We have a lot of guidelines out there. The one that we're using generally is the APA guidelines, which I believe it got updated either 22 or 23, so very recently, very recent for psychiatric guidelines. But there's a lot of guidelines out there. There's some German ones, there's some Dutch ones, there's British ones, and they all have contradictory information as to whether to use medication or not to use medication for anorexia nervosa. So some of them say use caution, use certain ones as opposed to other ones, whereas some of them don't even just say treatment should not be pharmacotherapy. We should not use antipsychotics. Use of antidepressants we are against use of antidepressants for core symptoms. So depending on which one you look at, we're going to look at APA. Current guidelines emphasize the lack of evidence for medications with AN. So all of these guidelines, there aren't a whole lot of good, robust, double-blinded studies for use of medications or the benefit of medications with patients with anorexia. Our pharmacological options are going to mainly circle around antidepressants and antipsychotics. You have not been exposed to these medications, so we'll go into brief when we talk about it in bulimia, but our SSRIs that we're really talking about are things like fluoxetine, citalopram, sertraline. Those are selective serotonin reuptake inhibitors. Generally, they're used for depression, for anxiety, which are large comorbid conditions, as we talked about earlier, in our eating disorder patients. But we found a little bit of benefit, but not great benefit. That's going to tell us 100% we can use these. There's also a class of drugs called tricyclic antidepressants, which is your amitriptyline, clomipramine, nortriptyline. They have some evidence. Their evidence is not as great as SSRI, even though SSRI's evidence is also not that great anyway. For antipsychotics, we have first generations. We have some evidence for haloperidol and some evidence for olanzapine and quetiapine. If you know anything about antipsychotics, especially second generation antipsychotics, you will know that one of the side effects is weight gain, and which we'll talk about that later on when we talk about some of these options for us. So a lot of studies out there looking at medications for anorexia nervosa. This one looks at fluoxetine augmentation as part of inpatient treatment. So giving fluoxetine alongside psychotherapy in a patient that is inpatient with anorexia nervosa. This one found after 7 weeks, they received 60 milligrams of fluoxetine. There was no significant difference between the patients that received fluoxetine and still got the psychotherapy and patients that received no fluoxetine and still got psychotherapy. So this one is telling us, not worth it. Don't give fluoxetine. This one looked at, once again, a fluoxetine with anorexia nervosa. They've also received fluoxetine 60 milligrams daily. And it looked like 29 out of 31 of these patients maintained their weight or was above the 85% average weight gain. So this one was a positive for fluoxetine. So whereas this one didn't say there was a difference between no drug or drug, this one said that between the patients that did receive fluoxetine, it was beneficial for them. They maintained their average weight gain, about 85% of them. However, this is important to note that this is not a double-blind placebo-controlled study, so it is not gold standard. We can't be certain whether or not this average weight control or this average weight gain or maintenance is due to the fluoxetine as opposed to some other treatment for anorexia, because it is not double-blind placebo-controlled study. Looking at olanzapine and anorexia nervosa, we've had 17 patients that were hospitalized between these 2 years. They were treated with olanzapine for up to 6 weeks. It was reported a significant reduction in depression, anxiety, which are comorbid conditions, and then core eating disorder symptoms, and a significant increase in weight. However, we don't know if that significant increase in weight was beneficial was due to olanzapine as a medication for the eating disorder, or because of the side effect that olanzapine typically adds about 7 kilograms on average to the patient that's taking olanzapine. So whether or not it's a medication side effect or because it actually beneficially helped the condition, we can't really tell. All right, so everything is what I'm saying. There is no FDA-approved medications for treatment of anorexia nervosa, which means all of the drugs we talked about, fluoxetine, haloperidol, olanzapine, all of those that we just mentioned in those studies didn't amount to an FDA approval of those medications. So there's currently nothing in the market to help you if you have anorexia. Or psychiatrists will most likely put you on some of these medications because these medications have proven there's some benefit, mixed benefit on these antidepressants or antipsychotics. However, the caveat here is you need to be ready to start these medications. The example that we have for fluoxetine, actually also fluoxetine, and olanzapine is that they can cause weight gain. If a patient isn't psychologically ready to gain weight, and they're gaining weight not because they're mentally prepared and they're doing the work and they're eating, but because they're on medication, it's going to be more destructive for the patient because they haven't fixed the underlying psychiatric condition and now they're gaining weight. So you have to be very careful with these medications, especially the potential side effects for weight gain. But in a patient that is ready to treat it and you have a constant vigilance by the psychiatrist, by the outpatient provider, there is some benefit for the use of SSRIs, TCAs, first-generation antipsychotics, second-generation antipsychotics. we should avoid Wellbutrin and QT prolonging agents. So Wellbutrin is another antidepressant. It's not listed on here, but Wellbutrin is, or bupropion is an antidepressant. The issue that we have with Wellbutrin is that its side effect is weight loss. So we already have a patient that is malnourished. We don't want to give him something that's going to cause them to lose weight. Additionally, one of Wellbutrin's well-documented side effects is the lowering of seizure threshold. And if you're anorexic, you're already malnourished, you already have an imbalanced electrolyte system, you are already prone to seizures. You're gonna do not give them a medication that's A, gonna make them lose weight, and B, it's gonna cause them to be more prone to seizures when they're already prone to seizures. Same thing with QT prolonging agents. Any medication that could potentially exacerbate prolongation of QT intervals can already affect something that's already being affected by the condition itself. So we talked about arrhythmias, we talked about cardiac abnormalities as a potential medical complication of anorexia nervosa. If you add another medication on top of that underlying medical complication, now you've developed, or you're setting yourself up for the patient to potentially actually develop cardiac arrhythmias, QT prolongation, base all the underlying cardiac dysfunctions that we talked about. So what are QT prolonging agents? Citalopram is a QT prolonging agent. Haloperidol is a QT prolonging agent. Olanzapine, amitriptyline, clomipramine, all of these are QT prolonging agents. So most of your antidepressants and most of your antipsychotics are QT prolonging agents. So we have to be really careful in the use of these medications, because while we might have benefits, especially getting them mentally ready to gain weight or mentally get rid of their other comorbid conditions like anxiety, like mood disorders, like impulse control. We are running into potentially exacerbating underlying medical complications that this patient may already have. All right, it's 2:55. You guys are here until 3:50. If is that correct?
Yes. Yes.
Okay. So let's go ahead and take a break now before we talk about bulimia nervosa. So meet me back at 3:05. All right, guys, it is 3:05. We can get started. We're about 2/3 done, so we'll definitely finish before 3:50. Okay, so we just talked about pharmacological treatment for anorexia nervosa. We just said that there is none. There are no FDA-approved medications solely for the treatment of anorexia nervosa. We should stay away from for disorder medications that can cause QT prolongation. Wellbutrin. Of course, we should also stay away from medications that cause weight loss, like phentermine. Stimulants can also kind of make you cause weight gain. It's not exactly contraindicated, but it's definitely something you should avoid if you are on anorexia nervosa or if you have anorexia nervosa. Okay, so let's move on a little bit to bulimia nervosa. So these medications have double-blind, placebo-controlled trials. We have imipramine, desmipramine, fluoxetine, sertraline, and then the other ones also have trials, but they're not exactly double-blind, placebo-controlled trials. So once again, we are talking about these are all antidepressant classes. TCAs are tricyclic antidepressants, selective serotonin reuptake inhibitors, and MAOIs are monoamine oxidase inhibitors. Trazodone is an atypical antipsychotic. Atypical antidepressant. It also has serotonergic activity. So when we're looking at bulimia, we're looking at imipramine as a placebo-controlled double-blind study. We have 22 people diagnosed with chronic bulimia. It says that 90% responded well, significantly reduced frequency of binge eating with improvement in other measures of eating disorders. Fluoxetine, we see a parallel multi-center double-blind randomized controlled fluoxetine clinical study, which is perfect. They used the Hamilton D for their depression scale, and they found that fluoxetine 60 milligrams improved significantly or statistically significantly improved binge eating and vomiting episodes in their under control patients or on their treatment arm patients. And then in here, we're looking at sertraline, another randomly controlled trial. We have 20 patients, typical age range between 24 to 36, so typical age range of someone with bulimia. Was conducted for 12 weeks. They found that sertraline had a statistically significant reduction in binge eating crisis compared with the groups who received placebo. So what does that mean for us? We see 3 studies here. We see imipramine, fluoxetine, and sertraline. They all said that these medications help improve binge eating, help improve purging compared to the placebo-controlled trials. So we have a actual FDA-approved indication for fluoxetine. The others did not pursue FDA approval, but fluoxetine did, and now we have a medication that is approved, FDA-approved, for bulimia nervosa. The others are also useful. We saw the study for imipramine and sertraline. However, fluoxetine is the only one that went ahead and pursued that. So when we're looking at the actual medications, the fluoxetine is the only FDA approved, so that's the one we have highlighted in pink. We have sertraline, citalopram, which are also serotonin selective serotonin reuptake inhibitors. Desipramine and imipramine, which are TCAs, and then phenelzine, which is a MAOI, and topiramate, which is actually an anti-epileptic medication. So all of these have been proven to be helpful in bulimia nervosa. Not all of them are FDA approved. However, there is studies backing their claim that it helps improve binge eating or purging, and has improved weight gain or weight management in our patients. Um, these are initial and maximum dosing. I am not going to be holding you to these dosing. I'm not sure what Dr. Hall has for your exam. But for adverse effects, however, when we're looking at all of these medications, everything but topiramate is an antidepressant. Okay, so that means fluoxetine, sertraline, citalopram, they are antidepressants. They're one family. Desipramine and imipramine are another family. And then phenelzine is also another antidepressant family. All antidepressants have a black box warning for suicidal behaviors in adolescents and young adults, which is the prime age range that we find patients developing anorexia and bulimia nervosa, right? So we have to be wary about this black box warning, especially with that 26% suicide rate for eating disorders. And for anorexia, there is a large prevalence of completed suicides with anorexia because they're already medically frail. So this black box warning is very important for making sure that our patients are safe in taking these medications. Jose, you asked earlier about the strike through. The strike through is that they don't have any. There is no placebo double controlled trials for these medications that have struck through, or if there is, they didn't come out positive. The ones that did come out positive are imipramine, desipramine, fluoxetine, and sertraline. Okay, so once again, antidepressants, suicide rate for adolescents and behavior, it's really tied into the mechanism of action. And all of these medications will take time to work. It's not it's not a GERD medication where you take it, like a famotidine, and the GERD symptoms kind of dissipate after a little bit. These take about 2 to 4 weeks to actually get some sort of clinical benefit. So it does take a long while. It takes months for this to reach clinical psychiatric benefit for the patient. But when they do, we find that they ended up reducing binge disorder, binging, and then the compensating behavior of purging. Another concern that we have for SSRI is that they may cause hyponatremia. We already have patients that are electrolyte deficient or electrolyte abnormality present in these patients, so we want to be wary about any other electrolyte abnormalities we might give them. And then a common side effect is nausea and then sexual dysfunction for the SSRIs and the TCAs. And then fluoxetine, which is the only approved one, can also potentially cause insomnia, so you got to be careful with that. For our TCAs, our desipramine and imipramine, they can cause orthostatic hypotension very easily and has strong anticholinergic effects such as dizziness, urinary retention. So be careful with our patients for those, especially ones that are restricting their behavior. They're already reducing the amount of things that they're eating or drinking, and urinary retention is not going to help that. For phenelzine, there are strong food-drug interactions, specifically around fermented foods. It can cause hypertensive crisis, which is an emergent condition. So that's something we have to, of course, counsel our patients on. But they have to be wary, especially if they are eating, if they're binge eating. Even though they're not technically imbibing the food, some of it might be enough in their stomach that it's going to cause this food-drug interaction. So be careful with that. Those are things that are fermented, liver, beans, jerky, so a lot of things that have tyramine and a cheese, wine. We have to stay away from if we are on a phenelzine or another MAOI inhibitor. Topiramate can also cause weight loss, which you shouldn't use this for anorexia anyway. So for bulimia, remember bulimic patients have already typical weight gain. Their weight is typical. They're above the 18.5. So it's not too big of a concern if we're going to cause weight loss. We don't want to tip them over to anorexia, so just be careful with that. It can also slow the cognition. Topamax has a predilection to slowing a patient's cognitive response, not physical response, but just how fast or mentally acute the patient is. So that's oftentimes especially if you get to higher doses, that is a complaint for most patients. For all of these medications,
That side effect after.
I can hear someone speaking, but I can't hear what you're saying.
Can you hear me better now? Hear me better?
Nope.
I'll just write it on the chat.
Okay. I'll look for it in chat. Let me pull up chat. So, so for all of these medications, we found that for eating disorders, we're looking at the higher ends near maximum dose range before patients start seeing benefits. We can't start them on maximum. We have to start them on initial. So it's going to take a long time for them to get to max. And then when they're there, it takes about 2 to 4 weeks at maximum dosing to get a clinical benefit. So we have to make sure our patients know that this isn't you take it one day, the next day you're good to go. There is some time. There is a temporal component to these medications. You need to take it daily. You need to keep up with it for weeks at a time, months, to get any sort of benefit. All right. Any questions about bulimia nervosa pharmacological treatment? I know someone's typing. It's not less intelligent. It's that their mental reflexes are slow. They can't think quite as much on their mental feet. Like if you ask them a question, it might take them a while to respond. Not because they're stupid or they're less intelligent, but because they're just taking a little bit for that process to kick in. Their response is going to be intelligent. It's going to be the accurate response typically if they already knew it. It's not going to stop memory or anything like that. It's just they're just slow to respond, like mentally. All right. So for binge eating disorder, this is the third category. We did discuss this with anorexia nervosa and bulimia. Those are kind of tied together in some of their symptoms. For binge eating disorder, we have a consumption of unusually large amounts of food. So it's very similar to bulimia nervosa. So consumption past the point of satiation, alongside a feeling of loss of control, and then feeling shame, guilt, or distress after that consumption of food. What's missing is the purging. So we don't have that compensatory behavior of laxatives, of diuretics, of vomiting. They just eat a lot, typically larger than what they would typically eat on a regular meal, have a feeling of self-control or loss of control, and then feeling shame or guilt after that episode. So binge eating, about approximately 2.8 million people in the United States have binge eating, and it's only very recently been recognized as an official eating disorder diagnosis when DSM-5 came out. That's when binge eating became an actual category. Typically, it starts very similar to the others. We talked about this in the late teens, early 20s. In women, it's pretty common in early adulthood. In men, it ends up coming a little bit later in midlife, as opposed to anorexia, where the patient is underweight, under BMI, less than 18, less than 17, and bulimia, where they actually are typically normal weight of about 18 to 23. Binge eating disorders, about 66% of them, more than 2/3, are typically obese. So it's on the other end of the weight spectrum. Okay. And then additionally, because of their binge eating, there's a complication. Now we have too much nutrient that you're eating because they're not purging it, so they're not removing it. So our long-term effects is going to be hypertension, diabetes, cardiovascular diseases, hyperlipidemia, osteoporosis, joint problems, sleep apnea. So as opposed to malnutrition and anorexia, a little bit of malnutrition and bulimia, now we're talking about too much nutrition, too much of a good thing, and binge eating disorder, where they're consuming large amounts of food. Therefore, they're going to have long-term side effects related to eating a lot of food. So our pathophysiology for binge eating disorder typically has some sort of hijacked reward system or emotional regulation tied to eating. So you're getting rewarded via your dopamine system, and you're getting an emotional regulation to some sort of trigger that's happened outside your life or outside of your control, and you're using eating as a way to regulate that trigger or that consequence. Our diagnosis criteria, once again, the same. First one is the same thing as bulimia, where they're eating a large amount of time in a discrete period of time, and they have this lack of control while they're eating. And then associatedly with the binge eating, you must have three of the following: you're eating much more rapidly than normal, as in you're mukbanging it up. You're eating until you're feeling uncomfortably full. So I don't know if anyone's told you this, but when you're eating, you should stop eating the moment you feel a little bit full. That's your stomach telling you we've had enough. Um, I don't do that, but I don't have binge eating. Um, but binge eating patients have that sense of satiation, and then they go past the sense of satiation, uncomfortably full. All right. Additionally, they're eating when they're not even eating alone because they feel disgusted about how much they're eating. And then, of course, feeling guilty for themselves for overeating. So there's that mood or personal component because you're overeating. We talked about the market distress. They must have at least an episode once a day for 3 months on average, and they're not associated with inappropriate compensatory behavior, not exclusive to the course of anorexia or bulimia. Similar to bulimia, binge eating disorder has mild to moderate to extreme, also tied into episodes per week. It's the same numbers as bulimia nervosa. So 14 for extreme, 1 to 3 for mild. Our treatment goals for binge eating is going to be to eliminate, hopefully eliminate our binging episodes, to treat these other comorbid medical conditions or complications that have come alongside binge eating, enhance, and the next three or four is all around your perception of self worth, of healthy eating, and making sure that we're trying to short circuit that dysfunctional thought process. We're also going to try to treat any sort of comorbid psychiatric conditions. One of the very first slides we talked about, we had all of those anxiety, mood disorders that are associated with binge eating. So we're going to try to treat that because that also might have an effect on how often someone binge eats. We're going to, of course, engage social and family support, and then we are going to hopefully ultimately prevent relapse or further episodes of binge eating. So for our pharmacological treatment, so once again, we are using non-pharm first. If that's not enough, then we start reaching for not pharmacological. We have a study here looking at lisdexamfetamine, which is Vyvanse, for the treatment to moderate to severe binge eating. And what they found was there was a mean weight loss reduction significantly higher in the Vyvanse group when you compare Vyvanse as opposed to patients that are not on Vyvanse. So Vyvanse reduced days where binge eating more significantly than placebo, so they reduced the amount of binge eating as opposed to placebo, and then there was a mean weight reduction on patients that were on Vyvanse than the placebo group. So what does this mean? It means Vyvanse is the only FDA-approved medication for the treatment of binge eating disorder. Okay, it is technically a stimulant, so as opposed to the other medications we talked about, fluoxetine is antidepressant. We mentioned some antipsychotics. Lisdexamfetamine is a stimulant. It's used typically for ADHD. However, it's also FDA approved for the treatment of binge eating disorder. So binge eating disorder has a touch of the impulse control issue, remember. So lisdexamfetamine is great for impulse control. It's ADHD is all about impulse control. That correlates to what the underlying pathophys or etiology of binge eating disorder. This is our typical and maximal dosing. Our adverse effect is we're going to decrease appetite, which is not really an adverse effect because that's what we want. However, it can also, if you continually take the Vyvanse, you potentially, and you're young, you could potentially have a decreased growth or decreased percentage in growth curves. And then because it's a stimulant, it's going to cause insomnia. If you take it often, if you reach near maximum dosing, you might have some cardiovascular side effects because once again, it's a CNS stimulant. And it can also exacerbate underlying psychiatric conditions in the patient. We have other pharmacological options. So this is the only FDA approved. However, there is some studies that do show some benefit of the other SSRIs we talked about, like fluoxetine and sertraline. Atomoxetine, once again, also a stimulant. So that makes sense. Venlafaxine, it's another type of antidepressant that's an SNRI, serotonin norepinephrine reuptake inhibitor. So now we're adding norepinephrine, which is a little bit of a weight loss issue, or weight loss medication. So it's helping with the impulse control, with the mood dysregulation as well, a little bit of weight control. And then we already talked about topiramate as a potential weight loss agent. So that's also going to help us, and it's helpful. Topiramate is also a mood stabilizer agent, so it's going to help us with the mood stabilization issue or comorbid psychiatric condition of our BED. All right, that is it. What are we at? 3:25. Any questions, guys? We have about 20-ish minutes. I'm going to let you go early because I know you have to do a quiz. Anyone? No one? I'm giving you guys like 15 more seconds to ask me questions. We'll end with just because we treated an eating disorder, we talked about the medical complications early on in the slides. There's going to be underlying medical complications even after we've treated the psychological component of eating disorders. So it's both it both tells us how to treat them, as in where to get treated, when to seek out medical help, things that we need to treat underlying conditions with. But once we've treated the psychiatric condition, we are also left with the medical conditions that have come alongside it. For anorexia, if you're malnourished, if you have poor bone growth, if you have if you have maladaptive and your growth curve, if you are amenorrheic, meaning your reproductive organs have basically shut down, we still have to fix that after we've fixed the anorexia. Same thing with BED. If we fix the binging, you might still be obese. So we might need to fix the other underlying cardiovascular issues that come alongside patients that are obese, the underlying metabolic issues that coincide with someone that's obese. So there's all of these underlying medical issues that we will need to take care of far after the fact that we fix these psychological issues. And these psychological issues will almost never be fully treated. It'll always be in the back of their heads. So they always will have some sort of follow-up with psychotherapy. They might end up not needing the pharmacotherapy anymore, but start with psychotherapy, you end with psychotherapy. Psychotherapy is going to be there for the entirety of your treatment option plan. Okay? All right. Any questions? Going once? Going twice? All right, guys. I'm going to let you go. Enjoy the rest of your day. And people immediately leave. Fine.
Thank you, Dr. Ong.
Bye.
Thank you, Dr. Ong.
Thank you.
Recording stopped.